Hey, all right, so this is like part two, I guess, so on informed consent. As I see it, this is kind of the more interesting thing. The ideas and everything about veracity and truth-telling kind of feed into this. I mean, they're interesting enough on their own terms, but this is kind of really where it's headed with those issues. So informed consent, it's a familiar concept. I'm probably you know about this. I think it's out there. It's been out there a while. People generally know what it's supposed to mean. But even there, I just want to pause on it and just think for a second, because sometimes, lots of people are inclined, upon thinking about informed consent to, of course, say something like, of course, that's very good. That's what we want. We want informed consent. We need more of that or something. And what they usually mean, of course, is, they're kind of laying the emphasis on the informed part, and that's kind of the basic underlying issue with the whole thing, and Vaughan discusses that too, right? We don't want consent to medical treatments to be mere assent or just acquiescence or whatever, but actually be an informed choice on the part of the patient. But that's what we don't want to lose sight of, right? When we talk about informed consent as what we want, it's not exactly right. I think what most people really should say, according to what they mean, what they're trying to say, is that what we want is informed choice, right? Or informed decisions, which could very well take the form of an informed refusal. So it's just good to keep that in mind, right? That, too often we might just speak about informed consent as if we're always prejudging that, of course, consent will be given, right? But sometimes that's where we're not so sure. When it comes to matters of autonomy, it typically is the case that it's in those situations of refusal or where someone declines medically recommended treatment of some kind or other. That's typically where autonomy shows up more clearly. That seems to be fairly obviously an autonomous choice because everything else was pointing in some other direction. Whereas in situations of consent, we're never ever so sure whether or not was it really an autonomous choice. Was somebody just intimidated by their doctor? Did someone not think they had any options, etc., or whatever? So certainly consent is good. We want it to be informed consent, but we always want to at least have in mind that, consent and refusal should go hand in hand, right? When we're thinking about these things as decisions that should be made autonomously. So anyway, some of those things are sort of touched on in the beginning parts in the Vaughan sort of introductory part of the chapter. It's fairly clear, lays out the basic issues, about how informed consent is not supposed to be just a passive acquiescence in whatever the doctor tells us to do or whatever, but is actually meant to be more of an autonomous choice. But it also gets into a little bit, and again, all of this gets taken up in some of the readings that we'll look at, is just that there are, lots of factors involved, right? It's a lot more complicated than meets the eye, or that when we just generally think about informed consent fairly abstractly, it might seem fairly easy to actually do or accomplish or implement in practice, but it's actually maybe harder than we think, and that's what some of these readings that we're going to look at touch on. So the first of those readings from Faden and Beauchamp, basically, as you can see, they distinguish two different senses of informed consent. The first is, I would just say, like the moral sense. That's basically the idea of autonomy, the deeper underlying reason why we think informed consent is necessary and good. And on the other hand, a more kind of legal, or say a legal institutional practice of informed consent, kind of how it actually is done, say, in the real world, so to speak. Basically, their main point is that these two things are really quite different. I guess that's perhaps not surprising, but maybe it is a little surprising. There is a discrepancy between them, so they just want to cast some light on the fact that the legal kind of institutional framework of informed consent doesn't always measure up to the deeper moral justification, right? The rationale or the deeper point for it in the first place. They're not opposed to there being two senses. I think they just recognize, on the one hand, the deeper moral sense really kind of points toward unique individual cases. That would be the ideal to be strived for in any given situation. But they also recognize the need for some way of basically determining or assessing whether adequate steps were indeed taken. And any kind of rules or laws are always expressed generally. They just have to be. It's inescapable. So there's always a kind of a balance that needs to be struck between these two things. It seems they just are of the view, it's probably true too, that, we might have some ways to go to trying to get the legal and institutional frameworks that we use to better reflect or more adequately reflect the underlying rationale in terms of patient autonomy. And the second reading, the other main one from Katz, is similar in many respects, but it makes some different points, and the emphasis is somewhat different. One of the differences, and this is kind of indirectly flagged by Faden and Beauchamp, is how Katz is basically assuming that informed consent or informed decision-making is or will be a matter of joint decision-making, right, between patient and medical provider, basically. Rather than, say, some more full-blown, just autonomous decision, or uniquely or individually by the patient, him or herself, basically. There may be, that may be debatable, but there may be some good reasons for seeing it in that way, basically. Not the least of which would just be the very fact that a lot of the information that is supposed to be disclosed from the side of the doctor or the medical provider, whoever it may be, is directly tied to the decision making, in the sense, for example, that, it will include information about certain alternatives. I mean, it could, in principle, exclude some, and that would be wrong. That could be a deceptive move. But it will include different kinds of options, and that itself sort of sets up the decision. So even at that level, just how those options, if they are at all presented, can be seen as part of the decision-making process. In a big way, another emphasis that's different here in Katz is just his discussion about medicine, about medical science, and just how it is that, contrary to what was once thought or what was once expected, which was that advances in medical science would, tend to reduce sort of the amount of decision making that would have to be made, right? That somehow the answers would just become clearer as medical science progressed. Something very different has, of course, turned out, that actually all new sorts of questions open up, new possibilities emerge that were never before. There's a lot more decisions to be made, basically. So, and it also, kind of hand in hand with that, he wants to emphasize this too, is just the degree of uncertainty in general about this knowledge. It's, it's not, I'm not sure what it means to say it's not rocket science, but the idea, it's not sort of an exact science, basically. And, especially the more things that sort of become available as sort of new possibilities, it's generally the case that, uncertainty is relatively greater there. And a lot of these uncertainties, gets mixed in, of course, basically with quality of life issues in a way that in the past they just wouldn't have come up. So that's another reason why there's sort of this jointness of decision making, I think, in his mind, because, the way in which the different medical or technological alternatives that may be available will have different consequences in a quality of life sense. And that's, of course, as we also know from, say, Goldman, those kinds of values or how those are relatively valued or prioritized is something that only the patient can do. So why, in Katz's view, informed consent is something of a fairy tale, or why it seems like a charade, or otherwise a kind of illusion, or something that's not really real yet, he really thinks, puts the blame or thinks has a lot to do with medical practice, the medical field, in terms of just habits, entrenched habits. He thinks that the medical profession is deeply paternalistic because it was for centuries and centuries and centuries exactly that. He thinks it's just really hard to break free of that. He thinks there is something like a kind of inflated self-conception among, especially, say, doctors, maybe not others in the medical field, as somehow, having a higher status or really being the ones who are supposed to help or whatever. I'm not really seeing their patients eye to eye, not being on their level. He really thinks that seems to be the main thing that needs to change to actually make that decision-making joint in the way that it's supposed to, right? Because right now it just still tends to be more on the side of medical professionals, not enough on the side of the patient, but to make it properly joined, which in his view would better realize the ideal of informed decision or informed consent and so on. That's what really needs to happen. Change is there in terms of the habits, the self-understanding of doctors in particular. So it would be like that basically Katz is, seems to really emphasizing this, that what's needed is just a kind of, a bringing down to earth or kind of deflating of the medical ego. And I think it's like this, to say that sometimes when there seems to be an overemphasis on the principle of beneficence, what that really is actually just doctors and others sort of wanting to be in control, right? And of course beneficence is under their control. But if you kind of properly deflate their ego, a little bit to where it ought to be, then it's probably a lot easier to see how beneficence and autonomy can be reconciled very well, right? The way in which, harm, for example, by failing to respect autonomy and beneficence, you could see those just going much more well together and not so much being counterposed. It's like whenever we see beneficence opposed to autonomy, seeing this tension, it could very well be that the real tension is just between doctor and patient, and the doctor wanting to be the one in control. The last thing then is that reading the Canterbury v. Spence case, kind of a landmark case, basically the one that laid out or expressed a general guideline for proper disclosure away from what had previously been called the professional model or the professional standard, meaning what doctors would think is appropriate and sufficient to disclose, to a reasonable person standard, basically thinking, no, it really ought to be what a reasonable person in that situation needs and wants to know, basically. So just a shift of emphasis in that. In effect, it's just trying to get that in practice that is the problems that both Thaden and Beauchamp as well as Katz are identifying here. So anyway, have a look at that, think about that. There is no specific quiz this week or for this material. Basically, next week there's going to be a midterm. So there'll be some, it's kind of like the quiz from this would be built into that. There'll be some other things as well, but I'll give you much more information about that in due time. For now, have fun.